Uh-oh, I hear echo. Hold on. I got the computer up. So good morning. Good morning. How are
Good
you?
morning. I'm great in yourself.
Where's my where's my background?
You know what? I had to reset because I couldn't get into my Gmail and I forgot I had to upload the picture again. I was like, you
Oh.
know what?
You be like me, be like, wait a minute, it's crunch time.
Yep. Because I had
I'll
to
see you
clear,
next week.
yeah, I had to clear out everything. And I'm like, darn it, I forgot.
Oh no. That's how I was this morning. I was like, did I send a link? I was like, I don't think I sent a whole link. How we not do that? Oh, goodness. All right. Well, welcome everybody. Welcome to our Saturday morning tea where we discuss health information, news, education, certification tips, all the stuff that the physicians are doing. um, the plight of nurses, entrepreneurship, just all of the things, the weather, you name it, we'll discuss that. I am Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, located in Cincinnati, Ohio, where coding education is key. And do you know what it takes to be a certified marketable medical coder? Do you really? Have you heard it before? Well, if not, before I introduce my co host, let me share with you information on a free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. All right. If you are in, you see me dancing. If you are in Clubhouse, feel free to click the link. If you are interested in getting more information about the 5 steps to become a certified marketable medical coder. And of course, if you're joining us via YouTube, Facebook, and LinkedIn, you can check out the video description box for details. I promise you it's in there. Just scroll down. So joining me today, yes, is my illustrious co-host, Mr. Jesse, the registered trademark, the coding nurse. Yes, put some respect on his name. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I am an LPN. I live in Philadelphia, Pennsylvania. I have been in healthcare for 30 years. During the pandemic in 2020, I created a company called the Coding Nurse LLC, where I help nurses and other people with clinical backgrounds transition into the wonderful world of HIM.
Cool. And how's that going for you?
It's coming along. I'm just
Right.
picking out dates for another class. But speaking of HIM, I ran across an article. How come they're talking about it's a pharmacist shortage now?
Really?
Yes. And some
Wow.
pharmacies have started to close early.
Well,
And
let me tell you about the foolishness that's happening here. Like Walgreens, they shutting up doors left and right up here. I don't know what that is about. First of all, they have purchased, they're like McDonald's. They purchased prime real estate on major intersection corners. And we have noticed recently that several Walgreens, it seems to be in areas of low socioeconomic uh, residents and are older adults where they're closing. So they're left with, where do they go to get their medications? Where do they go to get even advice or information? Because you can go in and have like your blood pressure taken or all of that. So they're just shutting them down with little to no notice. Let me just say, like, you drive by one day, it's there, the next day it's gone.
Wow.
Yes, it's crazy. So I don't know if it's a result of that pharmacist shortage or not, but yeah, it's crazy. It's wild.
Because I really think it might have some impact because when I lived in New York, when I took a hiatus from nursing and I was in, skincare and makeup, this
Sir.
yes.
Again, what has my friend not done? Y'all talk about me.
Yes.
This one right here.
I am a legitimate licensed cosmetologist and barber. But so this local chain in New York called Dwayne Reed went through this
Mhm. I'm
huge
familiar.
rebrand, and they started opening up these look boutiques in these pharmacies. Like they redid it. It looked like Sephora. So um, when we were in training, we found out that drugstores make their money from the pharmacy, not
Mhm.
from the sales of the other things in the store. The drugs are what brings in the money.
Mm. Hmm. Yeah, and I can see that because even with me being a caretaker and getting my mom's medication, I rarely go in the store. I'm in the drive-through. You can't get a sale off on me because
Mm.
I'm driving up, and a lot of people driving up. Wow. Wow, that's crazy. Okay, let's see who's it. Hi Shay, hi Stan, hi Lakeisha, hi Carmen, hi Renita, hi Vicky, hey the crafty coder. Welcome everybody to the tea. Okay. So, before we jump in, let me remind you, if you are on Clubhouse and want to join in and add to the conversation, remember this is a conversation. We open the room, even though we talk to each other and we talk to you, we want to hear from you. So join in. You can raise your hand. We'll monitor and check and see who wants to come to the stage, and we'll bring you up to the stage and join in on the conversation. Don't be shy.
That's
Your
right.
opinion matters here, and of course is welcome here. For my Facebook, YouTube, and LinkedIn friends, y'all already know what to do. Y'all use the chat because y'all use it all the time. And it's hilarious. However, if you have a question, please type Q first so we know it is a question and we don't miss it. And if you're joining via YouTube, when you come on in, don't forget to hit that like button as you enter. Thank you. We appreciate that. And if you're not subscribed, hit that subscribe button as well. I have a personal goal, 10,000 subscribers with a stretch goal of $20,000. Or see, I said $20,000, 20,000 subscribers. I guess I'm speaking that into the atmosphere
There
as
you
well.
go.
Speak it out. Speak it out. All right. All right. Church announcements. Church announcements. I don't think I have any church announcements this week. I don't think I have any. Do you have any church announcements, sir?
No, I don't. No, ma'am.
No, I don't think I have anything. Well, look at that. No church announcements. How we get that off? Um I'm trying to think of anything that I know that's come up. Um no, I don't. I don't. I've been busy. I've been trying to write papers. I got
Okay.
a 25 page intervention program plan to complete and write. So that's been heavy in rotation this week. And for
I'm
graduation.
sure.
Oh, well, I'm graduating. That's church announcements. It's
Yes, it
coming.
is. That's a big one.
It's coming. It's coming. So I guess that could be part of church announcements. I'm looking to see nobody in the comments got church announcements. I don't see any church announcements. Okay. Okay. Well, we'll move on from that. Okay, so let me just here look off collar church announcement. So I got the iPad and the laptop next to each other, and they had this continuity thing. So every time I scroll, it's scrolling over here on the iPad. I can't get it back over here to the laptop. It's driving me crazy. Okay, let me just vent for 5 seconds. All right, so let's get into it. Let's get into it. So if you are just joining us, today we're going to ask the question, who is the doctor? Who is the doctor? And then also brought to you by the Crafty Coder. We're going to talk about some Modifier 25 tasks that may come to a practitioner near you. Mr. Jesse, I don't even know if I know you sent me before the article about Cigna, and we could just start with them and their uh, review, their audit. Didn't you send me that? I thought you sent
I
me.
think so. Yeah. I think I sent it via LinkedIn.
Okay, you know, stuff be, but I'll be like, okay, did he put it here? Did he put it there? Where did he put it? So yeah, so our friends over there at Cigna, and again, this was one of those hot topics that one of our loyal supporters provided to us a couple of weeks ago regarding Cigna and their requirement to now ask providers to send in documentation when they're submitting Modifier 25 claims. And yeah, it's about to be off the chain. And I'm wondering. Oh, she said Cigna already started at her job this week. Actually, well, didn't they jump? Did they jump the gun? It looked like they jumped the gun. Because it said effective May 25th. So it looks like maybe they starting with y'all. Y'all got a problem with Modifier 25 over there? Anyway, so you know, when you Modifier 25 is added to your evaluation and management code when you perform a minor procedure along with an evaluation and management service. Now, it should be a separately identifiable, a significant separately identifiable evaluation and management service along with that minor procedure. And I think for some reason, folks are still kind of confused when it comes to a pending Modifier 25, because let me just say this. I think your billing world, their job is to make the claim go through. And so they may have heard or learned, hey, if you put the Modifier 25 on it, it'll go through. However, on the coding world, we also know and understand that there are guidance around appending that Modifier 25. And so if your E&M service is part of that minor procedure, it's, you know, it's associated with it, then you can't code for those two separately. So again, it has to be a significant, separately identifiable E&M service for you to add that 25 modifier. So that's just some education on the 25 modifier. But Cigna, who has it seems also recently got into a little hot water, and I don't know if this is as a result of that or not. But they said effective 25 or May 25th, but it seems like they jumping the whole gun already. They said they will begin denying claims, E&M claims with Modifier 25 when billed with a minor procedure unless the office submits the office notes to support the significant and separately identifiable E&M service they're submitting. So I think that's one way to kind of curb some of that. Just add the 25 modifier to it for folks, but they are definitely on a path that others may be following. So I said they tried to roll out this policy last year, but they got a lot of pushback, and they ultimately said that they would reevaluate it. And so what they reevaluation came up with was they're going to go ahead and push through. So it says their policy says Cigna requires the submission of office notes with claims submitted with E&M CPT codes 99212, 99213, 99214, and 99215, and Modifier 25 when billed with a minor procedure. The E&M line will be denied if Cigna does not receive adequate documentation to support that a significant and separately identifiable service was performed. The documentation should be submitted with a cover sheet indicating the office notes supports the use of Modifier 25 appended to the E&M code. Yeah. So that is going to be interesting. It says that the policy starts May 25th in most states. However, there may be different dates in other locations. So maybe that's why they moved early over there where the crafty coder lives. For instance, it says the policy doesn't start until June 11th in Texas. So yeah. What are your thoughts on that one there?
I want to start off by saying you're exactly right. It's all about education, because I will be the first to say I did not learn how to properly use Modifier 25 until you said something over a year ago.
Really?
Because what happens, what I learned after because it was here on Clubhouse in one of our morning teas. That's why people got to listen, because we give the knowledge here.
Mm-hmm.
They don't teach you that there is another document. There's a crosswalk that you can look at to see if the code can support the Modifier 25, because it's based on if the procedure doesn't have a global period attached, then you can't bill.
Mm-hmm.
But nobody teaches that, and all you have to do is go and download everything is on CMS.gov.
Everything.
You download it and you put in the procedure, and it comes up, and if it says 0 days, then you cannot append the Modifier 25, and if it does, then you can, and you're good to go. That has no, I don't even when I take E&M CEUs, nobody ever talks about that. So it's really, it all comes down to education.
Yeah, oftentimes I'm like, why? It's like sepsis. Like, why are they not getting this right? Like, what is it? Or some of the other high denial DRG issues, but this is on the other end. But it's like, I don't understand why not? What is this? And you're right, it comes down to just understanding education. Folks are not understanding and explaining. Folks are not understanding and explaining when it should be used and how it should be used. And it's like with all things right there in the guidance, and just a matter of reading. Let's see. My crafty coder is in here going, wow. Let me see. The part that everyone tends to forget is a portion of every procedure has a low level E&M built in. Exactly. So theoretically level 2 is included. Exactly. Like if you're doing just your vitals, if you're going to do that for the procedure. So yeah, it has to be. Oh, do you? We're going to have to talk about that. Okay, look. She said, wait, not the cover sheet. Yes, ma'am. They said a whole cover sheet. They're not playing. When I was studying for CPCI, E&M was a top missed concept. Really? Oh my God, E&M is my favorite. Well, and now with the new guidance, it's a little easier, I guess, but to me, it's about the same. It's just a different way to approach it. But I love E&M. E&M was always my jam. People was always calling me, could you teach us E&M? Could you come help us with E&M? This, and third. I mean, I could pretty much recite it in my sleep. I love the new E&M guidelines, though. Yes. Another person said a cover sheet. Wow. Yes, they said a whole cover sheet. They stop at everybody's dollars. Like, nope. But again, that's not only education for the providers, for the coders, but also for the billers, because again, their job is just to make sure it pushes through. And one way that I know, I've seen it, I've heard it myself. Oh, you just put a 25 modifier on and it'll go. Excuse me? Where does that happen? And so a lot of the stuff that happens on the front, I've always said this, what stuff that's happening on the front end is also affecting things that happen on the back end. And then somebody has to then go in and try to clean that up. So Cigna, with their new policy is rolling it out there. And
We should
letting
make
folks know.
we should make T-shirts. Modifier 25 is the new Modifier 59.
Look, they both together. Lord Jesus. Woo, Lord. I like that though. People be like, well, what does that mean? You got to be in the life. You got to be about it. Got to be in you, not on you.
That's right.
Oh my God. Yeah, that's gonna be interesting though. If other carriers follow suit. So to kind of bring this full circle, and I didn't pull up the LinkedIn art or the LinkedIn information or article that you sent me, but Cigna, they received an audit or review for some of their cases. I'm not certain if they were Modifier 25 or not, but stuff didn't meet the math wasn't mathing, and they got in trouble. And so maybe this is one of those ways to, maybe stop some of the bleed.
Look,
Good morning,
it's
Muhammad.
part of their corrective action.
Yeah, you're absolutely right. 59 and 25 has been on the OIG list since 2010, forever. And that was another one, like, it's right there in the guidance. But, I think folks have been so used to and taught to, well, we figure out a workaround or how to circumvent the process. Oh, well, this right here, this will help get it through. Well, yeah, it'll help get it through, but it ain't gonna help you keep it.
Right.
Doesn't mean it's right. So I think, and we talk about insurance companies kind of bullying, if you will, or gatekeeping, if you will. This is another way or opportunity for them to do that and save themselves. Let's see what she say. See, I'm trying to be on the team that sues the insurance company. I need that money. Wait a minute, let me tell y'all, both of y'all, between you and Mr. Jesse, who now wants to be law enforcement, the enforcer number one, y'all off the chain. But yeah, I think this is going to be really, really interesting going forward, especially if other carriers start to do that. I don't necessarily see the government payers denying off the top without they'll just come behind. I don't know if they have the manpower to do the wherewithal to do that. Right. But it'll be interesting if they decide, like, hey, they may be on to something. Let's try this. So, yes, Muhammad, you can ask a question. Feel free. Put a Q in there so we make sure we don't pass you by. We know it's a question. Let's see. Renita said, "You will not keep it. You're correct, because post-review recouping is very real." Oh yeah.
Very.
They get all their money. All their coins are coming back. You might be like, "Woo, don't spend it." Don't spend it too. I hope your cycle has some padded days in there, because you may have to pay it back. She said she believes they're going to follow once they see how much money they slow pay everyone. Yeah, they may. I'm just thinking about I'm sorry, I'm trying to read his question. Let's see. My question for same service and same visit date. Can we bill facility side with 99283 and professional side with 99284? Those are ED, I believe.
It sounds right? Like it off the top, yeah.
Off the top, it sounds like. So that there are different guidance for how a facility calculates their emergency department, because it's based on resources and all of those things. And fortunately or unfortunately, it's facility specific. So they have to come up kind of with their own way to decide if they use these resources, this equals a level of service for the facility in emergency department. Whereas on the professional side, we have the guidance that's provided for us in our CPT manuals, and they would have to abide by that. So yes, there is an option. You said this was for same service, same visit day. Okay, there is an opportunity for those things not to necessarily match because the physician may have done additional work, or the physician may have done some things to in his or her documentation and documented it that would require a higher level versus what the facility may have as their checklist for the various levels of service.
And especially if there was, laboratory or radiology testing, it's a lot.
Oh, that's a good question. Yeah, he said, yeah, that was ED. Yeah, without me picking up a CPT book, I'm like, wait a minute, I believe that 8.3 sounds like an ED to me. Okay, Renita asks, what about when the patient is seeing 99213 and go to therapy same day? What notes to send them? Again, you have to send whatever is to support that separately identifiable evaluation and management service. So whatever you're using to support the 99213 is what you're going to have to send. At least that's what Cigna wants. And wouldn't the facility be on a UBO for?
Not ED.
You're welcome, Muhammad. Anytime. Don't forget to hit that like on LinkedIn. Okay, let's see. Any other questions? We on the road with a whole different conversation, but okay. So look, thanks Cigna for helping us kind of dive in and dig into other things. And welcome everybody. I don't know if I've seen anybody else new, but welcome to those also in Clubhouse as well. All right. Any other thoughts, Mr. Jesse, before we move on to
No, I just think overall, like we need a lot more education in our industry. We really, really do.
I agree. And that's why part of it. So and we've had these consultations with people who are interested in the field and want to do, well, they don't really necessarily know what they want to do. But then when we have the conversation, like, well, what does your gut tell you? Are you more interested in inpatient? Are you more interested in outpatient? Are you more interested in the professional side? Again, it's great to have knowledge across the board. And I think that is part of what makes you marketable, if you have the skills to transcend all of those areas. But you also, if you're going to do that, you need to be mindful that there are guidance for each one of those areas, and you have to be in touch with what that guidance is and allow that guidance to assist you in making sure that you are coding appropriately. But if you choose to master one of those areas, then you definitely have to be in the trenches and understand what that guidance is and follow that guidance to the letter of the law. Let's see, she said the separately identifiable part is dictated by the provider, but the problem is usually that they knew the patient was going to therapy, so that's differently identified. So what's differently identifiable? The last visit, say, come back in a week. I'm trying to understand your question. I know it's related to the other, something with the therapy, I think. Mm-hmm. But there's two different people asking two different questions. So give me some additional stuff in there. And we'll come back to that.
All right.
All right, all right. So who gets to go by doctor? So who is the actual doctor? That's the next question we want to take a look at. So I think we talked about this a couple of weeks ago. Some folks were talking about, well, you have all of these people walking around in white coats. Who really is the doctor? And folks don't necessarily know Like who is the doctor? So I ran into an article from Becker's Hospital Review that kind of talked to various folks providing their perspective of doctor. And so doctor specifically is the person who has quote unquote doctor is the person who has used the title in practice. And it's how patients perceive all the different people who are their caregivers. And so, oftentimes you'll go to places and certain colors will represent what your role is in that practice or in that hospital. All the folks that wear these type of scrubs or who has this kind of coat, or that from your medical assistant all the way to the physician. So physicians pretty much are those who have earned the MD or DO degree, and they are permitted to use the doctor title and represent themselves as a doctor to patients. And everybody in that they talk to regarding this agree that's the case. But they said the American Medical Association, this is a line in the sand. So the president of the AMA, Dr. Jack Resnick, told Becker's this is an issue of, quote, clarity and transparency for patients. And he says there are immense differences in the education, training, and qualifications among healthcare professionals. We all agree. In healthcare settings, patients find it increasingly difficult to identify who is or who is not a physician, Dr. Resnick said. Truth in advertising laws, including those supported by the AMA, provide common sense, clarity, and transparency for patients, ensuring patients have the basic information necessary to make informed decisions about their healthcare, such as the license of the healthcare professional providing their care. I swear I felt a shot fired right there. From the nurse practitioner's point of view, I don't want to butcher her name. April Capu, I think is her name, which is she's a DMP. And she's the president of the American Association of Nurse Practitioners. And she agrees that patients have the right to know who is providing their care and be informed about the academic preparation of their medical caregivers. The AANP, again, which is the American Association of Nurse Practitioners, supports the use of the title doctor for doctorally prepared nurses. She said the organization opposes any legislation that would prohibit healthcare professionals from using their fully earned credentials and representing themselves in line with their licensure to patients. She also added that laws or regulations calling for, quote, anti-competitive and punitive measures that unnecessarily prohibit nurses and other health professionals from accurately communicating their education, licensure, and certifications to patients and the public, end quote, should be rejected. Woo! I feel them on the battle lines again. Here we go. This is training for nurse practitioners, and we talked about this, is based on the nursing model of education. Following appropriate training and licensures, nurse practitioners focus on patients as they test, diagnose, and treat their conditions. Then you also have the physician associates. Remember, we talked about them changing that from physician assistants to physician associate. From their point of view, it says physician associates use the medical education-based model for training as physicians do. PAs focus on testing, diagnosing, and treating patients' conditions. In 2021, the American Academy of Physician Associates voted to adopt physician associates as the official title for the physician assistant profession. Individual states must formally adopt the name change, and while many are considering legislation to do so, physician assistant remains the legal title for now. They The American Medical Association and the American Osteopathic Association remain opposed to changing physician assistant to a physician associate. Maintaining the title change will create confusion for patients. Okay, here we go. Here we go. They about to fight with everybody, right?
Mm-hmm.
It says, while the American Osteopathic Association recognized PAs and advanced practice registered nurses struggle to achieve professional parity. The president of the AOA, which is Thomas Eli D.O., Dr. Thomas Eli, said, quote, such efforts should not be at the expense of the truth in advertising and clarity of what is with that? Okay, the clarity of roles in our healthcare system, end quote. He said in a statement about the physician associate's title. Professional credentials, titles, and how we convey such information to patients is of great import and not a matter of marketing, he said. This title change could easily create confusion for patients and put their safety at risk. The American Hospital Association declined to comment on this story. So they said that the American Academy of Physician Associates, Jennifer, I don't even know what her title is, Jennifer Orozco. Oh my God, I hate to butcher people's names. But anyway, she's a DMSC and a PAC, are the initials behind her name. Said there is no reason to think that patients will be confused about titles. PAs are committed to being fully transparent about with our patients. The most important thing for PAs to do is to make sure they are transparent and clear with patients that they are a PA and that they are following state laws. I am Dr. Jennifer. So she has the doctor in front of her with one of her titles. I am Dr. Jennifer Orozco. I'm sorry if I butchered your name. But when I see a patient, I make it very clear that I am a PA. PAs who have achieved doctorate degrees, she added, should feel empowered to use the title that communicates their highest level of education in appropriate settings. She wants PAs to always be completely transparent about their medical titles with patients. However, the issue lies in the job title physician assistant. PAs do not assist physicians. They are a distinct profession. PAs are licensed clinicians who practice medicine in every setting and specialty. We are trusted, rigorously educated, and trained healthcare professionals. PAs are dedicated to expanding access to care and transforming health and wellness through patient-centered, team-based medical practice. So the gloves are off again, and now there's a three-legged fight now. What you thinking?
Well, the AMA has time and money, clearly. And it's really interesting because nobody would go to Ohio State and tell
Ohio State.
Right. The Ohio State and go to the psychology department and tell their chair, well, you can't use doctor.
Yep.
So there is a workaround, but the AMA is not going to be flexible because they just want things to stay the way they are. That's what it really is. Because they're not even offering any alternative. If they were offering solutions, then you could see, they are trying, but they're not trying to do anything. So I hope these other organizations continue to push forward.
Yeah, and so I see that somebody's legal team is all over this because they kept saying truth in advertising, and so they're setting up their fight kind of along that realm. So that's an interesting approach to this quote unquote legislation that I guess appears maybe in the works because they keep talking about legislation. I don't think it's fair. I agree. If I worked hard and I got my doctoral in terminal degree, everybody. No, I ain't gonna say that. I'm gonna say everybody better be calling me Dr. Warner
Right.
for everything. Good morning, Dr. Warner. Good morning, Dr. Warner. No, I'm kidding. But again, I've had nurse practitioners, and they're not necessarily doctor nurse practitioners, but they're wearing white coats, and they explain, I'm a nurse practitioner. I will be, in charge of your care, this, that, and the third, blah, 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 blah. Same way when they have, especially if you're visiting a teaching facility and you got residents all over the place and they use the term doctor and they still in school, they still learning. So you also have to make it very crystal clear. This is a resident that is seeing you. Or oftentimes they actually ask permission. Is it okay if we bring a resident in to do such and such and such? So absolutely, it's a way to communicate that to that patient. And I don't think patients are that confused that they won't understand, if you tell them this is what it is. And if they feel like, you know what, I don't want to deal with the nurse practitioner, or I don't want to deal with the physician associate, that's the choice that patient makes. But don't just say, oh, I'm the doctor, I'm the only one that you should be able to receive your care for. I don't think that is right, and that is fair either.
Because what I think should happen is, I think these nurse practitioners and these PAs need to help these MDs and their DOs with their documentation. Because if you want to run the show, you really should do a whole lot better.
You better say that. The Crafty Coder also agrees, and some PAs document better than the physicians. Y'all already know that. And nurse practitioners, nurse documentation has run medicine, because oftentimes you'll go back like, well, what did the nurse say? Good Lord, because nobody can figure this out. Wow. Yeah. Respect the titles, respect those titles. Those were earned. So I'm going to be that this is going to be something interesting to follow, especially if you start seeing some legislation come around where they're trying to keep them from being able to use their titles. They off the chain over there at the AMA. Bless their whole hearts.
I'm telling you, they just want to gatekeep. That's all.
Okay, I think they got a question to their answer to their question about the
therapy.
Yeah, because if it's not separate, again, if it's not separately identifiable, then you can't code them both. And they're saying that it was something that was ordered prior. The previous visit said that the last visit said they need to come back in a week. So clearly it's not a separate service. It's part of that therapy service. And so but it's not separate. There's no modifier that need to be added to them.
Because that's what, because I'm still not clear on the scenario, because who told the patient to come back in a week? Was it the doctor? Was it the therapist? Because the E&M code is one thing, but the PT codes are based off of, aren't they based in 8-minute increments? And you have to prove what you did. And that's different than, you're a physician evaluating. You're like, did you do manual, whatever, dexterity, or whatever the modality is to bill for physical therapy?
Y'all got something on that? Hey, Vicky. She said nurses. I'm sorry, I'm going back and forth. Nurses have been keeping notes forever for their patients. Exactly.
Well, you better.
So yeah. So if they put some more information on there, then we'll check it out. It's quiet over here in the Clubhouse.
It is.
It's quiet. But thanks for joining. We appreciate you. We appreciate you. Even though, like I said, I told you they done changed the whole thing over there. I'm like, I don't even know if the stuff is pushed out. I have no idea what is happening in Clubhouse with the new houses. I don't know.
It'll all work out.
It will. It will. So what's going on for the week for you?
It's this the usual. Still, working and grinding. I
Living and working.
Exactly.
I hear you. I hear you. I
Because
hear you.
when we finish, I gotta load up my Windows and start practicing some SQL.
Oh, how's that going?
It's coming along, but it's everything's about concepts, you know, and just practice. Like it's just like medical coding. You just have to do it.
Do it exactly. Like you learn the information, you learn the how to, but then in order to master that skill, you just got to get in there and do it. You got to see a note, see the diagnosis, see the procedure and what's going on, and then get out there and code it.
Because I was
She's so silly.
uh,
She said, I haven't been on Clubhouse in forever. I'll have to go over there so I can talk about these providers and raggedy documentation practices.
oh,
Let me drink
crafty
my
coder,
tea.
you be talking all day.
Mm-mm-mm. I wonder, do they have? I'm sure they do. Physician groups or physician rooms or something. I mean, are they having these conversations, or are they just talking about the administrative burden of documentation and the burnout and the what was the new thing we were talking about? I forgot.
Compassionate sacrifice.
Compassionate sacrifice, digital minimalization, all of those things. Maybe that's where they're focusing on, and not
Hmm.
the real. Like you can do more with great documentation. How about that?
You really
How
can.
about that?
Because, like, we always say here all the time, it's not what you bill, it's what you keep.
Hmm. Amen. Amen.
Because these insurance companies will circle back in a minute.
That's right. Don't hold your hat on what you pushing out there. You better hold on your hat on what what you're getting back, and after if it's been denied or not, you know,
All I can say is
fixing
don't spend it all.
it.
That's
Make that separate account. Like you
right.
got to have an account for your taxes and account the repayment account.
'Cause it's just a lot, and I can even just attest just from my job. Like, these people are getting sicker and sicker, and I just I mean, because I had done some research, and when somebody is readmitted within 30 days, you automatically get a 20% reduction in that next bill. Well, on that next bill, because of the person didn't go 30 days. And where I work, I have people who are readmitted in a week.
Mm. And I'm sure they know. I mean, well, because I remember there oftentimes somebody is monitoring that for on the facility side. Like it's part of their KPIs. They're looking to see, how often this occurs, the number of patients that are being readmitted within that 30-day time frame, and then what is the occasion for that, like what diagnosis or what condition is there. They're looking for trends. They're analyzing the data analysis, analyzing the data to find out what is happening and why it's happening, and then what they need to do to prevent it from happening, because to your point, they losing money
Hmm.
all the way around, all the way around. Okay. Craft Coder says, I've been talking all week to my doctors at the practice I work for. They are delusional. Literally, the guidelines say trained clinician. Mic drop. Be sure. Exactly. She said, I got it. Renita says, I got a denial on my NM, same day bundled with PT bill with 20 modifier 25. And she says, I'm a biller. Okay. Does she? No, this was something else. They are mad that they have to tell us low moderate, and high risk. But how do I know the level of risk? I'm not a trained clinician, nor do I want to be clinical. Yeah, it's up to the provider to um, document that. And all we're providing with is a tool to discern, or after we read their documentation, to kind of tabulate to see, okay, well, they mentioned this, that, and the third. This is appropriate for that level of risk. But it's up to the provider to tell the story of the patient, tell the severity of the patient, it's up to the provider to provide that information in their documentation. Because to your point, we didn't see that patient. You did.
Right. And all you can do as a coder, as a I guess I don't know what if billers, well, if you're a coder and you bill, you can query, because and then once you do and the answer comes back, whether you agree or disagree, the answer is the answer. You go ahead and put it through, and then if it gets denied, then whoever answered that query has to explain themselves, not you. Because I saw that, I did that earlier this week. The person came in with an infection, but they didn't meet the sepsis criteria.
Mm-hmm.
And because the whole principal diagnosis thing is the condition established after study. The after study is the key. And nowhere, of course, on the discharge summary was sepsis ruled out or anything. Actually, they were diagnosed with severe sepsis. So that implies an organ dysfunction. And there was no organ dysfunction. So I queried, was severe sepsis ruled in or ruled out? So they wrote back just sepsis POA. So, and then I also asked for them to provide the clinical indicators. They just put sepsis POA, no clinical indicators, because there are no clinical indicators. So I already know. So I changed it and put it through. And I already know in a few weeks or so, they're going to be like, no.
Mm. And that's, whoo, when you're dealing with, that's the one thing about inpatient. That's why, there's always been a heavy emphasis there, because that's money. You're talking mass money for stays, depending on what those DRGs are. So
they are.
it comes down to what we've said all along, the documentation.
It really, really does. And that's documentation and education. Documentation on the providers and then education on coding, CDI. Like, there's not enough quality education. It's really not. And the number one impediment to all of that, in one word, in healthcare, is ego. People think because I've been doing this for 10 years, you can't tell me nothing. But your work reflects like you've been only doing this for 6 months. Because if you don't
go ahead, I'm sorry.
If you don't understand the basics, it doesn't matter how long you've been doing it. That means you've been messing it up for 10 years.
Exactly. And we are in a profession that requires lifelong learning. You're going to learn something every day. You're going to learn something all the time. You learn something new all the time, and nobody knows it all. Nobody
That's right.
can say, "Oh, I am the expert in so and so and so and so and so." And yeah, you may have mastered it and have an expertise in it today. Y'all know how our stuff rolls. It changes tomorrow. So then you have to learn and then master whatever the new changes are. So it's a constant learning, a constant revolving door to stay current and knowledgeable in our profession. And you know what it is when you signed up for it, right?
and that's really, people think that auditing is easy, but the trick that people don't understand about auditing, especially when you audit for the government, is CMS will go back 3 years. So if you audit something from 2019, you can't use, or 4 years, you can't use a 2023, you can't use the 2023 guidelines. You got to go all the way back and look up the guidelines for that year. And you done moved on and, oh, well, that's old, I can't do that anymore. You done darn near forgot about it, but you got to go back and like read it. Like, this is what was in effect at the time.
Which is why, so I got my books back here. I always keep 5 years sets worth of books.
That's
Which
right.
again is why it's important to at least have a manual. I mean, I know the EMR or the 3M and encoders of the world are great. And I guess they have a way to go back and possibly they don't. Okay. Well, that's why it's always important, because you never know. You may need to understand and say, well, I did it because back then the guidance was so and so and so, and you have to be able to defend that. You're absolutely correct. Absolutely correct. I don't know. It's a lot. Folks need to get off that ego thing. I think there's ego all around. Yep. There needs to be some humility.
Exactly.
Let's humble ourselves and speaking truth to, you don't know it all, and it's okay that you don't know it all, and it's okay to say, I don't know it all, but I can find out, or I'll find somebody who can find out, so this stuff is done right. And I'm just so, when we talked about that, was that last week or the week before, my heart was just hurting. Like, if it's so many people out here that is in our profession and don't know what they're doing and just sloppy at it and not applying this information on both sides, on educator sides, on the actual coding side, that just hurts. That hurts.
It does, because what in my experience, like, people try to make everything gray, and it's not.
It's not. It's only gray if you're trying to play the game. You're trying to work around and you're trying to figure out, well, what can I do to make this a yes? No. Sometimes it's just going to be a no, period. And it's okay. Take the little coins versus no coins at all. Or you having to give back coins plus some. Because that's the other part. We talk about how they're recouping the money on the back end, or asking, hey, we saw that this, then a third, and if you can't provide the appropriate documentations to support, you need to do this. Don't let that elevate and escalate to, oh, we see a whole pattern here. We're about to extrapolate all of this for the last 5 years or 3 years or however many years that they choose to do so. And now you have to pay this plus 3 times plus this additional fine. Don't get to that game. Pay attention. Y'all got to pay attention to they're giving you some rope. Right. And trying to see, okay, are they changing? Are they hearing us? Are they, and are they applying the information that we're trying to tell them? If no, they coming for you a little stronger. They're not gonna keep playing this game with you. Like, yeah. Yep. Continual education. She said continual education is a requirement. If it gets to the point where you're no longer learning or desire to learn, just leave. Continual education is required in this field. Absolutely. So at my old job, I did hospital AR, and they had so many TRG reviews for sepsis. So I was like, yeah.
Because it's the catch-all. You can just because somebody has tachycardia and a fever, that you meet the sepsis protocol.
So yeah, that rope will hang them later. Stop playing with insurance money. Absolutely. Yeah, I know I was talking about that F word that folks don't like to talk about, fraud. Fraud and abuse. They take it all together, fraud and abuse. And once those words get thrown out, it's a whole different ball game.
Yeah. Because it's a lot of money. People People have no idea how many billions upon billions of dollars are spent on healthcare every year in this country. They have no idea.
Mm. Or they can't fathom what that money looks like. I think that's part of it. Yeah, that's crazy. Well, to your point, I just think, maybe we need to kind of check our egos at the door. For my clinicians, really at the end of the day, it's all about having qualified clinicians to take care of our patients. The patients are what this should always be about. That should be the focal point of all
That's
that you
right.
do. And so hopefully, just can y'all all get along? Can y'all all get along? Everybody has their passion and desire to help patients. Let that be the focus versus trying to gatekeep or keep somebody else from doing a job that needs to be done. Because you may not have the passion to provide care to someone in a rural area. Somebody else may have that passion. Let them do that. It's okay. It's okay.
But what I think it all comes down to is when people and I think that needs to be explored more, the whole medical model versus the nursing model, because the entire healthcare system should be collaborative. And when you are in nursing school, part of the nursing model is you are always taught that you're part of a team. And every nurse that works knows that they can't do it by themselves. That's why, as a nurse, I will never, ever, ever talk bad about CNAs or techs, because if you have a good relationship, they will save your career.
Mm.
Because you don't have time to go look at everybody. If you have a CNA or a tech that says, Ms. Johnson don't look good, or they're not, their usual selves, they're usually more perky, you better go check it out.
And I think the physicians also recognize that there's a team concept, but they're taught that they are the leader of that team, and pretty much what they say goes. And they don't necessarily look to the team members to assist them in managing the care of the patient.
Well, it's a huge difference between leader and dictator.
True. You're absolutely correct. There's leadership skills are a must, and maybe that's another piece of it. Do they have the appropriate leadership skills to do that, to run those teams? That's true. That's a whole other conversation, ain't it? Yeah. What'd she say? They above us, saying stuff like this. What we pay you people for? Wow. Wow. It's crazy. There's a lot of things to think about. You never think about all that goes into this whole healthcare system and how it's all intertwined. It's all connected.
Yeah.
It's all connected. And it's all connected to, okay, I'm putting on my public health hat. It's all connected to the outcomes, the patient outcomes, and what happens in our communities.
It is. Because the sad part is, it all rolls downhill, and, marginalized communities always pay the highest price.
Definitely.
For all of it.
Definitely. Cool. All right. Well, this was good. This was good. Uh-oh. I'm still chuckling about you. I learned something from years ago.
Exactly. It's the truth. And then once you hear something, the burden is on you to go and educate yourself.
Amen. Amen. You know me, I always have my trusty notebook right here. I take notes like, oh, wait a minute, let me go back. This is, yeah. You know me, I'm I'll go back and research. I need a better understanding about that. I've heard this, that, and the third. That's just my makeup. I don't know where I got it from, but that's just my whole makeup.
It comes from all your years of being in HIM, because now I am a beagle. I just snoop around. I'm like, what? Okay, well, let me go look this up. What?
Right. Like, what is that? And
Yeah.
between that compliance, let's make sure, is it right? Let's make sure this is right. What did the rules say? What does the guidance say? That's my first. Wait a minute, what is this? Now, what did the rules say? Let's throw that up against there and figure out what is what.
Speaking of guidance, remember when I had contacted you earlier this week about the fine needle biopsy?
Mm-hmm.
I was, I was a little perturbed about the whole situation, because I looked up the guidelines in 2023 in PCS, and it said lymph node biopsy. They have any other kind of disclaimer. Lymph node biopsy is coded to excision. So this is in the 2023 guidelines, but the coding clinic that they came back with was from 2018. So if the coding clinic changed that in 2018, why is that guidance not updated in the 2023 PCS manual or the 2022? I'm like, because you need to know that.
You do.
Because it is not customary when you are coding to go to a coding clinic.
It shouldn't be.
Exactly. I strictly use my book 95% of the time. So to be, when they come, I'm like, in 2018 at that? No. There needs to be some update.
Yeah. When you told me that, I was like, really? That?
Because
that'll be back and forth all day.
Because my sticking point, and I'm all for like, what does it say? And when you go to, I've always been taught in coding that when you have a main term or any kind of subterm, if it is not a non-essential modifier, all of that wording has to be there in order to code it. And it did not say aspiration. It just said fine needle biopsy. And what made me comfortable with the excision was because it was for lymph nodes that were by the aorta. So I'm thinking, well, they're using a smaller needle to lessen the chance of, nicking the aorta.
Right. So
that's why I went with, the excision as opposed to, they were saying extraction. Because so it's just like, but once again, if there was guidance in the ICD-10 PCS guidelines, then it would be okay. Well, then that's what it says, and that's what it is.
Yeah, she said this. She was like, your 2023 PCS manual should at least reference the 2018 coding clinic.
It doesn't. Because actually the PCS manual period doesn't even reference coding clinics, only the CM. Because you know how in the tabular index in CM, it'll give you the exact coding clinic. But when you go to the table in PCS, it's not, they don't reference coding clinics.
So how are you ever supposed to know if there's a question or right? Look, we both said it, like that's crazy. How are you ever supposed to? Wow.
Because even if that updated guidance was there in the table when I got to excision, okay, then I could, well, let me just take a look and make sure. But no.
She said she doesn't do PCS, so she never knew. That's interesting. And nobody said anything about this for all of those who code for inpatient procedures using PCS?
Apparently not.
Wow.
Well, but once again, I learned from you that when they have these reviews, because best believe when they have the comment, the open comments, when they start getting ready for the October guidelines, I'm going to issue a comment like this needs to change.
Yes. Look at that. That's right. So we have these platforms where you can make those recommendations and bring it to somebody's attention, because maybe that's all they need. Somebody needs to say something. That's true. All right. Cool. Look at us. Please me walking away with a smile.
That's right. So you come to the Saturday morning tea to get information to be empowered.
Yes. And to be, sometimes we give you information to be on a swivel.
Right.
Make sure you got a good understanding of what is happening in the environment around you. But also to give you information to help you in your day-to-day and long-term career aspirations. So, well, thank you all for joining the Saturday morning tea. Again, was the tea spilled today? Was it spilled today?
Absolutely.
Yes. Empowered and informed. Exactly. I love it. So if this information was valuable for you, help us share this message with others by liking the video, sharing the video, and subscribing to the Professional Reimbursement Network channel. You can also check out the Coding Nurse channel on YouTube and subscribe there as well. There are gems over there. Don't sleep. Don't sleep. Last but certainly not least, to my Clubhouse folks, there are no greenhouse anymore, so just join the house, I guess. Right. Come on into the house. We have the Certified Marketable Medical Coder house over on Clubhouse, so feel free to join and be a part of that. And you can get in when I do go over there and post little things sporadically, because I'm not a huge poster on Clubhouse, but you will get notifications of our live broadcast. And that happens every Saturday morning at 9 a.m. Eastern Standard Time. So you will get those notifications. So again, this has been a great session. Mr. Jesse, do you have any last final words?
As always, I thank you for creating a space, because we really need information, and we need to have a community where we can ask questions and grow and learn together. So thank you.
Well, you're welcome. I'm glad that I could do it. And it's fun for me. It's a learning for me as well. Trust and believe. I learn something every week. So this is great for me as well. Right. So again, this has been a great session today. Thank you all for joining. And remember, be safe, be kind, and don't wish for it. Work for it. Until next time, take care, and we will see you soon.
Can I see you backstage for 5 minutes?
You can.